An older woman, found confused at home. Her blood sugar is 1100. Not a typo, 1100. But here is what is strange. Her ketones are negative, and her pH is normal. This is not DKA. It is HHS. And her real problem is not the sugar. It is that she has been slowly drying out for days, and her blood is now as thick as syrup. So where do you start? Here is your question. An older adult with type 2 diabetes is confused. With a glucose of 1100, no ketones, a pH of 7.34, and a serum osmolality of 350. Which action is the priority? A. Give a bolus of regular insulin to rapidly bring the glucose down. B. Begin aggressive isotonic IV fluid resuscitation. C. Administer sodium bicarbonate to correct the acidosis. D. Start an insulin infusion now to stop the hyperglycemia. Pause right now and commit. 3, 2, 1. The answer is B. Aggressive isotonic fluids. The glucose is sky high, and every instinct says reach for insulin. But in HHS, the problem is water, not acid. This patient is down as much as 10 liters. Fluids are the treatment, and fluids alone will bring that glucose down substantially before insulin does much of anything. Here is why it looks so different from DKA. In HHS, there is still just enough insulin to block the breakdown of fat, so no ketones and no real acid, but there is not nearly enough to control the glucose, so it climbs and climbs, often past 1000. All that sugar spills into the urine and drags enormous amounts of water with it. Day after day, the patient dries out. The blood becomes hyperosmolar, thick and concentrated, and the brain, which is mostly water, begins to shrink and misfire. You are here, profoundly dehydrated, confused, on the edge of shock. So line it up against its cousin. DKA is the acid one. Younger patients, type 1. With ketones and a low pH, and a glucose usually somewhere between 300 and 600. It comes on in hours, and insulin is what closes the acid gap. HHS is the water one. Older patients, type 2, no ketones and a normal pH, and a glucose that can run past 1000. It builds over days, and the treatment is fluid, and more fluid, same family, completely different enemy. So here is the order of operations. First, fluids. Aggressive isotonic saline, because the deficit is enormous. Second, potassium. As you rehydrate and eventually add insulin, potassium shifts into the cells, so you watch it and replace it. Third, insulin. Low dose, and only after the fluids are running. In HHS, insulin is the assistant, not the star. Here is the rule to carry out of this HHS with its extreme glucose, high osmolality and no acidosis. Fluids first and foremost, insulin is secondary and it comes after resuscitation, not before it. So how do you know it is HHS and not DKA? The numbers: a glucose over 600, often far higher, an osmolality over 320, a pH above 7.3, no acidosis, a bicarbonate over 18, minimal or no ketones, and an altered mental status that tracks with just how high that osmolality has climbed. Notice what is missing from that list: the acid. That absence is the whole point. And keep the two drugs in their lanes. The fluids do the heavy lifting. They restore the volume, improve the perfusion, and lower the glucose all on their own. Insulin only fine-tunes the glucose from there, and it must not go in before the fluids. In DKA, insulin was the star, because it closes the acid gap. In HHS, there is no gap to close. Water is the treatment. Insulin is the assistant. Now about the pace, because HHS has a corridor of its own. The deficit is huge, so you start aggressively. The first liters go in fast. But the osmolality is extreme, and if you drop it too quickly, water rushes into brain cells that spent days shrinking, and they swell. That is cerebral edema, and it can seize or kill. So it is a two-speed correction: aggressive at first to rescue the circulation, then deliberately gradual to protect the brain. And the warning sign is cruel. A patient who gets more confused as the numbers get better. 2. To lock in. For the picture, HHS is high and dry, with no acid. H, huge glucose. O, osmolality up. D, dry, with no ketones. And for the priority, fluids first, insulin last. F, fluids first. K, potassium watch. I, insulin low and late. When the sugar is this high and the ketones are absent, your hand goes to the fluids, not the insulin. Now the wrong answers. D, start the insulin infusion now. It feels right. The glucose is 1100. But in HHS the problem is water, not acid. And insulin before fluids can deepen the shock by pulling what little fluid is left into the cells. That is the trap. A, an insulin bolus to drop the glucose fast. Even worse. With the osmolality this high, crashing the glucose invites cerebral edema. And C, sodium bicarbonate, there is no real acidosis here. The pH is 7.34. You would be treating a problem this patient does not have. Tie it together. Your cues: glucose 1100, osmolality 350, no ketones, an older patient who is confused and dry. Your action: aggressive isotonic fluids first, then low-dose insulin, replacing potassium and correcting gradually. And the outcomes you are steering toward: the volume restored, the osmolality easing down slowly, the mental status clearing, and no cerebral edema on the way. Now test yourself. Same age, same sky-high sugar of 640. But this time the ketones are positive, and the pH is 7.10. Same disease? No. Those ketones and that acid mean this is DKA, not HHS. There is not enough insulin to block ketogenesis. You still start with fluids, but now insulin has a second, essential job: closing that anon gap. In pure HHS, there was no gap to close. The ketones and the pH are what flipped it. One more. 2 hours into treatment, the glucose is coming down nicely, but your patient, who was waking up, is now more lethargic and she is complaining of a headache. What do? You slow down. Worsening mental status while the numbers improve is the red flag for cerebral edema from correcting the osmolality too fast. Slow the fluids, and the glucose fall, and escalate. This is an emergency. Better numbers with a worse brain means you move too quickly. One last look. The HHS is under control now. The numbers trending the right way. Do you stop there? No. HHS almost always has a trigger. Most often an infection, sometimes a missed medication or a new illness. This patient has a fever and a productive cough. It is pneumonia. Treat the trigger, or the HHS comes right back. Fixing the sugar without fixing the cause is only half the job. Next episode. Blood pressure 78/40. Sodium low, potassium high. A patient craving salt, with a strange bronze tint to the skin. This is an adrenal crisis, and there is one drug you give before almost anything else. What is it, and why the rush? That is episode 5.